And I will welcome you once again to Fort Hall Forum at Suffolk University. We thank our generous sponsors, including, among many others, the Lowell Institute and Suffolk University. The forum also thanks its members, whose generosity makes free public forum events like this possible. If you're not yet a member, please grab some information on your way out. It is very important to us to have members, and you do get benefits, so there's a little sheet there that tells you what the benefits are. I would like to introduce to you this evening our moderator, Jean McGuire. McGuire served as the Massachusetts Assistant Commissioner for Public Health for 5 years, and most recently, for 5 years as the Assistant Secretary of the Executive Office of Health and Human Services. She's worked as a healthcare lobbyist in Washington, D.C., and she's led national policy organizations and coalitions in HIV/AIDS and disability. McGuire's policy research currently focuses on public health regulatory and financing practices under the Affordable Care Act. She has published work in the American Journal of Public Health, the Journal of Acquired Immune Deficiency Syndrome, and the Journal of Public Health Management, among others. Professor McGuire joined the Northeastern faculty in 2003. She left to serve as Assistant Secretary in 2007, and she returned to the Health Sciences Department in 2012. Please welcome Jean McGuire.
Thank you, and thank you everybody for coming out on this evening. This is a really interesting conversation to be a part of, and it's so current, and it was an opportunity for me both to join with previous colleagues and to meet some new individuals. So coming into this, I thought about 20 years ago, and right about this time I was Assistant Commissioner for Public Health and on a radio show, and had a call from a doctor who was treating people with HIV/AIDS and said, "You're the government, why can't you let me just tell this woman that her husband has HIV/AIDS?" And on the face of it, that was obviously such a sensible thing for the doctor to be saying. It was painful to her to know the man was infected, the woman didn't know it. And she thought government should be preventing the spread of infectious disease, and it was logical to ask government to intervene. Tonight's panel is really about the challenges that we have in both the ongoing epidemic of HIV/AIDS, the new epidemic of Ebola, the many things we've had before and since SARS, avian flu, the things we're still trying to understand, the Middle East respiratory virus syndrome. They all have different characteristics in terms of the number of people that have been impacted, the nature of the infectiousness, the strategies about prevention. We've had 75 million people that have had HIV/AIDS in the world. Half of them are dead, half of them are living. In this country, there's 1.2 million of them. 15 to 20% of them don't know they have the virus. The risk of transmission is real, even when you do know you have the virus. In the case of our newest disease in terms of Middle East respiratory virus syndrome, we have about a 50% death rate that's occurred over time. And so these are all impacting populations in different ways, in different burdens, in different risks. And what they share is an expectation that providers and clinicians like Dr. Naheed are going to come to the fore and take care of people, that government, many people at the CDC, at the WHO, here in the state government, are going to protect the public at large, that lawyers like Professor Annis are going to figure out the right way for us to design the laws and to balance security interests and protection interests with individual civil rights, and that representatives from the State House, like Carl Sciortino, who now runs the AIDS Action Committee and works nationally and in the state on HIV/AIDS issues and is a person living with HIV, are going to help us navigate the contours of when it's okay to tell and what is it okay to restrict. Ebola provides us with the newest and most significant example of the struggle that is going on nationally and internationally in terms of embracing the challenges of an outbreak that's the largest one in the history, that has recorded 24,000 cases over about an 8-month period, over 9,000 deaths, and is seeing small bits of resurgence, as it has over the last 40 years that we've been aware of it. So we are at the cusp of ongoing work, of ongoing challenges, and we have a great group to talk about the new epidemics, the old epidemics, and how does the public and government and clinicians and people affected work together. So I'm going to introduce everybody, and then we're going to open up the conversation. First here, we look forward to your engagement. Immediately to my right, Dr. Nahid Bhadelia is an assistant professor of medicine in the section of infectious disease and associate hospital epidemiologist at the Boston Medical Center. She's also the director of infection control at the National Emerging Infectious Disease Laboratory at BU. Her specialization is in infection control issues related to emerging pathogens and highly communicable infectious diseases. Aside from her clinical training in infectious diseases, Bhadelia has a background in international affairs and human security and conducted her master's thesis examining the impact of pandemics on macro-level health indicators and community security. She's previously worked on a project funded by the Global Fund for HIV/AIDS, tuberculosis, and malaria. Most recently, Bhadelia was part of the WHO organization operations in Sierra Leone to combat the Ebola outbreak. Next to her is Professor George Annis, is the William Fairfield Warren Distinguished Professor and Chair of the Department of Health Law, Bioethics, and Human Rights of Boston University at the School of Public Health, and Professor in the Boston University School of Medicine and School of Law. He is the co-founder of Global Lawyers and Physicians, a transnational professional association of lawyers and physicians working together to promote human rights and health. Annis came to Boston University in 1972 as the director for Center for Law and Health Sciences at the law school. He's the author or editor of 19 books on health law and bioethics. He has written regular features for the Hastings Center Report, the American Journal of Public Health, the New England Journal of Medicine. He is a fellow of the American Association of Advancement of Science, a member of the Institute of Medicine, a member of the Committee on Human Rights of the National Academy of Sciences. He has been called the father of patient rights. And he also was a wonderful instructor for me. Carl Sciortino is the executive director of AIDS Action Committee, the first since 1982 to be living with HIV. From 2005 to 2014, he was a state representative, Massachusetts legislator, and a leading advocate on HIV-related legislation. Before that, he served as vice chair of the Medford Democrat City Committee, was founding member of the Progressive Democrats of Somerville. And his professional experience includes working as a manager of research operations at Fenway Community Health Center and a research associate at Beth Israel Deaconess. Let's welcome them all, please. So I want you to get to know them a little bit. So each of the panelists is going to take about 5 minutes at the beginning. And I want to start first with Nahid and ask her to talk to us about her recent experiences in Sierra Leone. I think it's 3 times you've been there over the last 6 months or so. And I really want Nahid to locate us in the challenges of patients and providers in terms of building a response on the ground as an epidemic is unfolding. I've also asked her to provide a particular lens on the importance of case identification and isolation as a part of both a containment and a treatment strategy. Nahid.
Great. Thank you, Jean. Rainy day, I'm glad we're all indoors, right? I actually want to start by defining emerging pathogens. You've heard that term, a couple of times already. So it's basically any infectious disease that is now newly recognized to cause human disease, or it is an infectious disease that is causing an excess of cases now that wasn't before, such as Ebola, or it is a disease that has changed somehow. So a lot of resistant bacteria and such fall into that as well. The reason I wanted to define that is because, before I give you my own experience, I wanted to set the scene of what emerging pathogens do. Emerging pathogens basically test the kinks in our public health armor. And they do that because what they're really doing is they're challenging us to determine a response and create policies while we're still learning about the science of the pathogen itself. So that's a challenge. The other thing they do is they also accentuate the inequalities between the communities that have a lot and the communities that don't have that much. And you see that over and over again, those that are impacted by influenza, those that are impacted by Ebola, those that are impacted by HIV. Look at who gets the largest disease burden. And then lastly, what they do is they reveal to us how connected we are as an international community. Decisions made here impact communities everywhere else, and vice versa. For example, decisions made in China in the setting of an emerging pathogen, influenza, impact the caseload, impact potential transmission to us. So with that, I sort of wanted to shift and talk about my own experience. As Jean said, I've been to Sierra Leone, initially with World Health Organization in August, and I was providing patient care to Ebola patients in Kenema Hospital. And then since then, I have been twice, once in November with Partners in Health, again with patient care, and then this last time I had the good fortune, again going down with Partners in Health to work with Ebola survivors, which there are many of. So to sort of set the conversation, as Jean put it to me, some of the largest challenges that we had in terms of providing care to Ebola patients, I can't start the conversation without stressing human resources. At our Ebola treatment unit, we had about 100 patients, 80 to 100 patients. There were only 4 of us expat clinicians, and there were about 8 national nurses. So why? Why is that? And it was an awful ratio. It sounds an awful ratio, but it was even worse because our own time in the Ebola treatment units were limited by the time that we could spend in personal protective equipment. We could spend at any one time an hour and a half, 2 hours. And each of these patients have a disease that requires really hands-on treatment. So all those things, complicated and impacted our ability to respond. The other thing that impacted it was the fact that there weren't, at that point, that many healthcare providers who had training in this. You remember MSF was one of the organizations that really had a lot of the training. So it was very hard for people to volunteer for this because they weren't ready to do it safely. The other was even if you were, there weren't any networks to get you down there to help. I ran into physicians in January when I would talk about my experience in August, they would say, I've been trying to get down here since August. I just never heard back from the website where I put in to volunteer. So that was another element that made it hard. And then on the scene itself, the difficulty was getting people down there who are expats because their ability to come down was limited by the restrictions that were placed on them. When you return and you have 3 weeks, or your job says, you can't go, it really takes out a lot of people from the volunteer pool. For example, anecdotally, there were about 10 nurses and doctors with me in November. 4 of the people down there had to either quit their job or were fired. They were basically told, if you go down there, don't come back. And so it's not a very good incentive to get people to volunteer, right? You're already doing something that's supposedly dangerous. And then locally, for national nurses, as you know, but all 3 of these countries lost a lot of healthcare workers. It's almost 500 healthcare workers that lost their lives to this, and they had very few to begin with. And then there wasn't much of a plan early on. There is now, in terms of how do you respond to healthcare worker illness? Do you put them into the same ETUs as their patients? Do you have another setup? And then, everything else that you've heard recently in terms of the inequalities of access to care for these patients. So there's that. And then the other challenges were physical resources. The decisions that were made by private companies, for example. Suppliers stopped flying, as you know, in August, and we couldn't get physical resources like personal protective equipment. There were days in August that we had to decide what we're going to do if we run out of PPE, which is the personal protective equipment. What do we do tomorrow if we run out of aprons? Do we leave our 100 patients inside? And that was a direct impact of the decisions made somewhere else, And complicating that also was, even if the physical resources were there, this was the kind of epidemic that was occurring in all major areas in 3 countries. It wasn't localized in one place. Let's say you got it in Port Loco. There might be another epicenter 2 weeks later somewhere else. So that really impacted our ability to provide care. So shifting it to just our own experiences and some of the ethical dilemmas that we face taking care of these patients, there's so many. Every day, and I asked one of my coworkers saying, what would you say in terms of the ethical challenges? She said, every day there's like 17, I don't know what you're talking about. So there are 4, though. They've all fall under these major umbrellas. One is this idea of not being able to provide the kind of care your patients deserve. Because there's not enough resources. So instead, you're providing the kind of care you can. And, that's a dilemma. The other is having to balance your own safety with the survival of your patients. If you have to decide, oh, I'm too tired, if I stay here too long, I'm going to make a mistake, but that means leaving this patient may impact this patient's survival, that's that's a hard thing to do. We don't generally make that decision here as physicians. And that's a unique one to this particular outbreak. It's closer to sort of a war zone situation, right? I mean, most people, when they go to treat an outbreak of cholera, are not really worried about their own lives. The other is, what do you do when patients come to you and they don't have Ebola and they have something else? So you can't really admit them to your Ebola treatment unit, even though you know that if you leave them outside, they're going to die. And the reason you can't is you're going to put them into a suspect area with other people who may have Ebola. So you might give them Ebola. And the last one, which I'll end with, which Jean had asked me to talk about, is this idea of who do you put into your Ebola treatment unit. People present to you with fever and chills. Guess what? Many things look like that, right? Malaria, typhoid, loss of fever, diarrhea, which is the basic sort of fever, diarrhea, and simple sort of presentation of diarrheal disease is what this disease looked like. It didn't look like some scary disease. Patients with Ebola look like patients with cholera for the most part. So you can't really tell the two apart until you have tested them and you've figured out who's positive. But to do that, you have to admit them. You have to isolate them from society. But you're also putting the individual at risk, as I mentioned, from getting the disease from other people who may have it. So for the most part, we have great case definitions that allow us to figure out who goes and who doesn't. But there's always that line in between, right? So what do you decide? Do you decide what's better for the individual? Do you decide what's better for society? If you put this person into the unit, then you're actually stopping the propagation of potential cases in the community. But by doing that, if you put them in there and then you release them because they're negative, they may turn positive because they just were exposed in the suspect ward that you exposed them to, and they're going to go on to cause further cases. So there was no right answer. You see the uncertainty. You see sort of some of the dilemmas. So I'll end there.
That's a good start. Thank you so much. And it's a great lead into George. And I really wanted George, who's had a very historical presence and big presence in terms of addressing the dilemmas of government and its authority and its responsibility for protecting the health of the public and treating affected people in the context of various infectious diseases. And he's got a lens that goes from looking at flu and HIV and SARS and other pathogens through Ebola and all of our post-bioterrorism efforts in this country and elsewhere to kind of further construct what the rules of the state are in terms of security for people, undertaking the police authorities that public health has, and the dilemmas of then successfully balancing the security and well-being of everybody with the health and welfare of individuals who are at risk. So, George.
Thank you. Saying I have a historical view means that I'm old. And that's okay. I am. I realized listening to Nahid, and it's great to be here with Nahid and Carl, that we had some of the same issues back in the 1970s when I was on the Board of Registration of Medicine here in Massachusetts, the beginning of the HIV/AIDS epidemic. Many physicians, I would even say the majority of physicians, took the position that they didn't know anything about AIDS, therefore other doctors, specialist doctors, should take care of patients who had AIDS, and they shouldn't. And I was proud of the organization I was with, the Board of Registration of Medicine. We actually issued a regulation saying that it was your responsibility as a Massachusetts physician to learn how to take care of people with AIDS. That was not an exception to being a physician. That was part of being a physician. And that there was not a lot of resistance to that once we said that. And that I think is right. Now I wouldn't say exactly the same thing. Should every physician have to take care of a patient with Ebola? That's a little more specialized. On the other hand, I would say, if we had more cases, I'm happy we don't in this country, that we should not, well, this may be debatable, say that, people with Ebola have to go to the 4 hospitals that specialize in that. They can't go to any other hospital. Every hospital could just ship them there. But thankfully, we don't have to face that issue in the United States. Well, there is a real epidemic of Ebola going on in Africa. In the United States, it's been solely an epidemic of fear. Never had anything approaching an epidemic. But we learned a lot about ourselves during that about 5-week period. Do you remember that? When Ebola was #1 story everywhere. And then all of a sudden it went away. And 5 governors, including Governor Cuomo and Governor Christie, totally flipped out and said that everybody coming into the United States and their airports was going to have to be screened and be, if they'd been anywhere near anyone or any country where there was Ebola, they'd have to be quarantined for 21 days. And Governor Christie actually started quarantining a nurse, you may remember Casey Hitchcock's, who challenged them, and rightfully so, right? Because the law in the United States is not that we balance civil liberties and public health. That's not the law. The law in the United States is the U.S. Constitution, and the law is that you cannot restrict someone's liberty unless, you know, there's a valid public health purpose, and you do it in the least restrictive alternative. So you could argue that it was valid to have Casey monitor herself during that 21-day period, but you could not argue that the least restrictive alternative was to lock her up in a hospital in a tent in New Jersey and watch her. You know, it was just stupid. And it was nice to see a judge immediately say that, that's right. And there was a compromise worked out where she would monitor herself, which she was always happy to do. And that's generally been what's happened since then, although there is the threat of force right beneath the surface. No one since Casey has challenged the 21-day, not really a quarantine, voluntary quarantine, I guess we'd say. But it's easily challengeable. There's like virtually no scientific data to support that. And that's the second point I want to make. Whatever you have an epidemic, whether it's HIV, AIDS, SARS, the flu, or Ebola, the first thing you want to know as a public health person is what's the epidemiology, what's the science of it? Now, how do you catch it, if you will, right? When are people who have the disease a risk to other people, and when are they not? All right? We had the hysteria over Dr. Sensor taking a subway ride and going bowling and having a pizza in New York. You may remember this case, right? Became the most famous Ebola patient in the world probably for a while. And that was a total overreaction. Although he turned out he did have Ebola, but he didn't infect anybody else. And nor did Duncan infect anyone else besides the 2 nurses who were taking care of him, even though his whole family was living with him for weeks. So it's not easy, at least in the United States. I won't say I don't know anything about Africa, but it's not easy to get the disease here in the States. It's just not. It's just not. We've got, and so public health shouldn't overreact. And the way public health sometimes overreacts, usually it doesn't, usually it does a pretty good job, is to either treat the public as the enemy, when the public has to be colleagues in this. Public doesn't want to get sick. The public doesn't want to spread diseases. The public wants to help and will respond in any reasonable way as long as it's a credible medical person telling them, or public health telling them what to do. Number 2, you need leadership to respond to any type of pandemic. All right, and that it's going to be useless unless you can coordinate, the leadership can coordinate the response and has the trust of the public. Okay? Now, there's 2 things, and I'll quit. The U.S. is structured in kind of a, well, not a strange way, but it is, in some ways it is an anachronistic way, in that the public health powers are all state powers. They're powers of the individual states. So each individual state can go off on its own if it wants to. It doesn't have to coordinate. You can argue about whether it was smart or not for the president to name an Ebola czar, but actually it made sense because there was no one who had the authority to coordinate responses across jurisdictions in the United States, and certainly not across countries. Remember, the U.S. sent its military over to Liberia to help build infrastructure, not actually treat people, but to help build infrastructure. So that made some sense because the federal government has no direct authority in this. Right? The CDC tried to coordinate information and makes guidelines, but it has no line authority at all. And I think made some bad mistakes there at one point. But as bad as coordination in the United States is there is like nothing worldwide. All right, there's no world government, we know that. The UN has no direct authority anywhere, and the WHO has no direct authority. The whole world community is based on the notion that each country is sovereign, and each country can make its own decisions, and does. So the US literally couldn't go to Liberia, let alone Guinea or Sierra Leone, without the permission of those countries, right? And actually, the US was asked by Liberia to send its military forces there. Of course, if Liberia hadn't asked, that would be called an invasion, right? And so we can't do it. We don't have any setup like that. MSF made it clear that the WHO was not doing a job, couldn't do a job, but it never really was the WHO's job. They never had the authority or the resources to be the agency that reacts first when there's an epidemic. Should we have such an agency? Yes, we should. How could we set it up? We're going to have to set it up the way almost everything is done in the wake of any major epidemic or disaster. It's done by volunteers. Yes, we need someone to coordinate the volunteers, but what you want are to have people who are trained beforehand, who are willing to go and help in an emergency. Do we have that? We actually have some of that in the United States. We don't have it internationally. Internationally, that hole is filled by NGOs, non-governmental organizations. The most famous physician one being Doctors Without Borders and Partners in Health too, of course. But they're totally volunteer groups. Right? They don't rely on government funding, and they don't work for the government. And God bless them. If they didn't have them, we'd have nothing. So that's enough. That's just an introduction to our discussion. And there are many ways this can go. But it's kind of interesting that in the United States, we have a very difficult time coordinating response because we don't have any federal authority in public health. And internationally, it's worse.
Well, there's a hopeful note. Make sure the volunteers are ready to go. It's so wonderful to have Carl here and to have a number of people also in the audience that have a history of deeply working on the HIV/AIDS epidemic. Because this presents, so Ebola, hopefully we're going to be able to mount a serious, proactive, forward-thinking, preparedness-based response that's ultimately going to get to better testing and treatment and prevention. In HIV, we have an epidemic that's got 30 years of history in this country that has lots of resources in terms of treatment options, and we still have dilemmas in terms of what it's like to live with an infectious disease, what the role is of individuals themselves who are negotiating that, what the responsibility is of clinicians, and what the role of the state is. So, Carl, I'd like you to kind of locate us on that lived experience and the dilemmas as you see it in terms of the U.S. policies right now.
Sure. Well, thank you for having me here, and glad to be on the panel with both of you. The name of the forum tonight, just the word virus. Virus is kind of a scary word. If it was called bacteria or disease or public health, those are sort of safer ways to talk about this. But the word viruses are kind of scary. They're these weird little things that people don't really know much about. And I say that because for people that are living with a virus in their body, for me, having HIV now for a number of years, I have this little invader in my body that people are really scared of. And the idea of being contagious or infectious or living with an infectious disease has implications for people still today for a virus that people are very familiar with for the most part, 30 plus years into an epidemic. When I was talking to Jean and to Jen about this forum tonight, and I was thinking about what people know about HIV. So I've been at AIDS Action Committee for just a year. I served in the legislature for a decade before that. But in my time at AIDS Action, just in the last year, what I've been blown away by, frankly, is how many people have come to me and said things along the lines of, oh, that's really nice that you're doing that AIDS work. Is that still really, an issue? I don't know much about it. And there's sort of these two competing narratives in our culture right now. One narrative is that there was this thing called the AIDS epidemic, and people died, and it was terrible, and somehow it got better, and treatments are good, and I don't know much more about it. That's the end of the story. And there's another narrative, which is that there's a virus, people are living with it, Some people do very well on the treatments, and some people do really terribly, and some people still die from it. And both of those narratives are still there because they're both still true. So in this state in Massachusetts, as was alluded to, we still have a growing number of people living with this virus. There are about 20,000 people in Massachusetts alone living with HIV. There are roughly 700 new cases per year in the last few years, which doesn't sound like much, and in fact, we've made a lot of progress. We've had a 41% decline in the number of new infections per year in the last 14 years. We're in the right direction, but we still have 700 new people that were infected last year alone in Massachusetts. So today, if you are infected and you're living in a place like Massachusetts, when I got diagnosed 5 years ago, I knew there was treatment, but I frankly didn't know really what that meant for me as a human being. What is it like to get on treatment? I had this image of fistfuls of pills and diarrhea night and day and nausea. And I had this weird, what are the side effects like of these treatments, and lots of misperception about what it is. And a lot of stigma, a lot of fear for myself and for my friends, we're all well educated, but still a lot of fear in that issue. I'm one of the lucky people, quite honestly. I get to take 1 pill a day. I have no side effects. If I didn't take that pill every day, I wouldn't really know I had a virus in me. My virus is completely suppressed by that 1 pill a day, so I'm not actually infectious to other people. It's one of the greatest breakthroughs of treatment today is that if you are on treatment and you're virally suppressed with HIV, you are not infectious. That means you don't transmit to other people. That's a really groundbreaking piece of progress we've made in this epidemic. But at AIDS Action Committee, we have literally thousands of people that we see every year, our clients, for whom taking a pill a day and going to the doctor every 3 months is not actually a manageable process. The idea of managing a chronic illness for someone like me with a job and a house and insurance and social support, I can take care of myself. But for our clients, dealing with mental health issues, addiction and substance abuse issues, homelessness, how do you keep a bottle of pills on your person when you don't have a place to sleep tonight? Or if you're couch hopping and you're terrified that someone might find your bottle of pills. Or you have mental health issues, so the idea of going to a doctor is really terrifying to you, or just not in your wherewithal. So what we actually do literally every single day at AIDS Action Committee is we give people intense case management, peer support, social support, and we literally will walk people, hold their hand, walking them to a doctor's office as often as we need to keep them healthy, and we do very well with them. But the word virus is still there. That contagiousness is still there. So when I think about public health epidemics in the history of HIV, there was a time not too long ago when people were calling for quarantining of people with HIV. When it was still the gay plague or the gay cancer, it was put all the gay people on an island and lock them up. That was a real thing being called for by some people in this country not too long ago. And while we were never quarantining people with HIV in the state legally, we absolutely still today, to this day, have social quarantining. We have a social apartheid, if you will, around HIV. The goal is get tested, good public health measure, get tested, know your status. If you know your status, you're more likely to go on treatment and not pass along the virus to other people. That is a good public health message. But it also means that when people know their status, or think that they know their status, if you get tested today and you're HIV negative, you're only HIV negative at that moment. If you go and have sex tonight, what does that mean for tomorrow for you? That status, though, HIV negative or HIV positive, has created in some ways a social apartheid in our community. One of the public health interventions has been, if you are HIV negative, God forbid, don't have sex with somebody that's HIV positive, because you'll get that virus. And for some people, that may have been an effective intervention. That may have been an effective way to not get the virus, not get exposed. But for many people, it was false security. So in this country today, after 30 plus years in the epidemic, where people know what a condom is and know how to get one, we still have 50,000 new infections every year in this country. Most of them are sexual transmissions. Most of them are sexual transmissions. And when you hear people talking about HIV today, the word sex is not mentioned very often. We don't do very good sex education in our schools. We're not actually talking about HIV today because we think it's something of the past And we've lost sight of how it's still infecting people and affecting people today in 2015. There's a lot I could say about this. I'll just tell you, I'll stop with one quick story. Just this week, our legal services department got a case of a client who was in a local hospital, one of the best institutions in the Boston area, who shall remain nameless for now until we actually go to court. Person with HIV, our client, in the hospital for something totally unrelated. And in the hospital bed with family and friends around, supporting this person in the hospital bed, the nurse comes in and says, in front of the entire family, "So have you taken your HIV medication today?" And the patient freaked out and said, "Oh no, that's not HIV medication, that's for something else." And the nurse said, okay, and left. Second nurse comes back in 20 minutes later. "There's some confusion about your HIV medication. We want to make sure that you're on your treatment for your HIV," in front of all the friends and family. And the patient started, "You have the wrong person, you must be mistaken, this isn't, no, that's not me." Leaves the room. An hour later, a doctor walks in full protective gear as if this person had Ebola, quite honestly, and said, "We need to talk to you about your HIV treatment and your medication. There's some concern you're not adherent to your medication." That client of ours has now lost her partner, who knew she had HIV, but didn't want all the friends to know that he had a partner with HIV. The family is now estranged from her. Nobody actually knew besides her partner. And I know very many people in my social network and in this city, progressive bastion, Massachusetts, who are living with HIV today in absolute secret because they're terrified for anybody to know. Why? Because we don't talk about it. We don't talk about it. We're living in the past as if it was 30 years ago, and people don't know what it is today, and that secrecy and that shame have real implications for individuals and for public health.
You know, maybe, I wonder if Nahid, I was going to go in a different direction, but, you know, Carl, you did such a great job of characterizing that. I wonder, Nahid, before we started tonight, you were talking yourself about how Stigma is operating in Sierra Leone and in your time just there. Can you talk, even among people that have recovered, can you talk a little bit about that? Because, and what does that mean then about moving forward in that epidemic?
Yeah, you know, Carl, just so great to hear you talk about this, you know, and some of the things that you said very much resonated with the stories that I heard from Ebola survivors. You know, there's the first level of stigma, which is stigma to anyone related in any way to Ebola. So healthcare workers have absolutely no symptoms, right? Tons of national nurses actually were driven out of their villages. We had a couple of national nurses who had to stay on the grounds of the Ebola treatment unit outside the hot zone because they had nowhere else to go. You know, then there's the stigma of the actual patients, how they were treated. Patients, when I spoke to, this last time that I was there, we were doing trainings for survivors so they could get employment. And, you know, when you start talking about Ebola survivors, they have these like incredible stories that come out. They talk about like how they think they got it, and they talk about not what they were treated with, but how they were treated. You know, they talk about feeling like exactly this, like living with something inside you that nobody wants you anywhere near them. Doesn't even want to touch you, even if that means that you may, you know, die. Nobody wants to touch you. And then that sort of fear, the sort of seeing that fear in people's faces, seeing that response continued for a lot of survivors even after they had completely recovered, had absolutely no chance of infecting anybody else. You know, one woman told me that when she goes for her regular checkups, people just make you go through triage, right? They do, what we do is now we go through and take temperatures of everybody who goes to a regular hospital in these affected countries. People would basically throw her stuff to the ground and just say, "Stay as far away from me as you can." And this is after this person is completely recovered and probably immune, you know, to the disease. And these are patients that have lost everything, right? The survivors, what nobody talks about is most of the survivors drop probably an entire socioeconomic status level. When you're an Ebola patient in a lot of these affected countries, they burn all your belongings. right? Because they may be contaminated. So you take all your valuables with you. You take, your property deeds and your certificates and your national ID card. You take them to the Ebola treatment unit because that's where you're going next. But nothing that gets into the Ebola treatment leaves the Ebola treatment unit, except for the patient who's now been bathed and, and recovered, which means people lost all these things. And if you really think about it, if that were happening, it's a matter of organization. If that were happening here, do you really think that many of us would lose our iPads and iPhones going into Ebola treatment units? No, it's a matter of a will of how certain people, it's okay for them to lose things and for others it's not, And so that stigma continues, and it's not just cultural stigma, but it's actually financial, it's political, it's identification. A lot of them lost their national ID cards, for example. This one guy came up to me and said, "That's great, you're giving me this training stipend. I can't open a bank account because I don't have any identity." So, yeah.
Wow. I think that one of the interesting things of the time that we're in right now is that the knowledge is still evolving, the responses are still evolving, and sometimes they go backward before they go forward. So at the end of February, the Presidential Commission on Bioethics here in this country issued a report saying that the quarantining of returning healthcare workers, and they were particularly focused on Casey Hickox and the really absurd things in New Jersey, but that it was actually morally wrong. So this is the Presidential Commission. In essentially the same week, the CDC issued a report on group quarantine in Lagos. So an individual who had flown into Nigeria who was turned out to, in fact, have Ebola, had a number of contacts. A country as populous as that, if Ebola had spread there quickly, we would be in a very different circumstance right now. The CDC report, our same country, issues a report saying the efficacy of group quarantine in Lagos, in Nigeria, in terms of containing the spread of Ebola. And even on the best day, it's hard for a scientist to hold these two ideas in place. It's certainly hard for a legislator who doesn't have, and maybe that background, but for the general public to say, oh, quarantine's morally wrong, but it actually works. In the last 2 weeks, Guinea has closed its borders because of a resurgence of cases in Sierra Leone. So this question about how do you move ahead in containing a risk, having a knowledgeable response. So George told us public health, has to present us with the scientific evidence on the basis for which to make decisions. Right now, the evidence is evolving. And so my question for all of you is, well, what do we do with uncertainty? There's uncertainty, Carl, even in your conversation, for how protected people feel like they can be, how much can they protect others that they love. What do we do about uncertainty when we have to make public decisions and we have to make individual ones? And I want to start with George, and a recent article that was reflecting on Peter Sandman's work said we should basically be proclaiming uncertainty. And then we should engage people in understanding what's either an acceptable risk that science might measure, or reasonable risk, as lawyers tend to talk about it. But how might we restructure the notion of what we don't know and how we still have to move ahead? George.
I mean, that is a question. Americans do, not just Americans, but I'm most familiar with Americans, are terrible at dealing with uncertainty in just regular doctor-patient relationships. I think we do expect our doctors to tell us, diagnose what we have, and tell us how to treat it, and expect them that everything's going to be fine. All right. First, many times they can't tell you what you got, and when they can't tell you for sure the treatment's going to work or not going to work. Right? And we hate that. And you can multiply that 1 million times when you're a public official, and you're worried about how the public's going to respond if you don't act to contain something that later on turns out you could have contained it. You could have made it better, right? That these are things what we call you're taking a small risk of a catastrophe. Well, I don't blame them. Politicians don't want to take any risk of a catastrophe because that's the end of them. It really is the end of them. You may remember, may or may not, but I remember back in 1976, the great swine flu epidemic in the United States. It never happened. Gerald Ford was told that the chance of having a flu pandemic in the United States was unknown. And he said that was the scariest word that he could hear. So he recommended, started this flu vaccine program that every man, woman, and child in the United States was going to get the flu vaccine. And 65 million people got it before it turned out there was no flu epidemic. In fact, only one person died of the flu that year. And a lot of people were getting Guillain-Barré syndrome from the vaccine itself. So the vaccine was more dangerous than the disease. But it was that word, uncertain, unknown, that his Secretary of Health and Human Services told him was the chance of having an epidemic. All right. So I don't have it. There's no answer for that. That's actually a political question more than a scientific question. So I would ask you, how does the governor make a decision like that?
I'm glad I'm not the governor.
No, I understand. But you have more experience than I do.
So when I was in the legislature, I was on the Public Health Committee, and there was a bill several years ago that was going to update our state's quarantine laws. And it was...
Make it more effective?
It was actually, the laws had not been updated since the early 20th century. And so science has evolved a lot, and people's understanding of disease understand a lot. But the quarantine laws hadn't changed, I think, since the 1920s, if I remember correctly. And this seemed like a kind of a normal thing to want to do in legislative practice, is to look at your ancient laws and say, do these still apply today with what we know today in science? And it should have been a simple thing, but it was actually the uncertainty. You know, have most of you seen the movie Outbreak? Or there's these movies about viruses, right? And at the beginning of the scene, you see like a little primate gets something and does something, or someone spills something, and you know this is the beginning of a really bad movie, right? Everyone by the end is gonna be dead. Like, and in real life, you don't know when things are happening. I think with Ebola recently, is this the beginning of the Outbreak movie where this is gonna get really bad, or is this the beginning of the, oh, that was so silly of us to have been so scared a few months ago? You don't really know when you're in the heat of it, right? So you want your laws, if you're going to have laws that say you can lock people down in their homes or in their communities, you want to have some sense that that's not based on this unknown, are we in the beginning of the movie Outbreak, or is this really a thing to be afraid of? And so when this was unfolding in the legislature, I got a flood of constituents contacting me, people from around the state contacting me, really in a panic that we were going to update the quarantine laws. Mostly, they didn't know we even already had laws about quarantine, that we actually already had legal authority to quarantine people. But a lot of it was folks in the anti-vaccination movement, and people saying you can't force mass vaccination, the civil libertarians, I'm a card-carrying ACLU member. It wasn't my friends in the ACLU that were pushing this, it was people that were really saying, you can't force public health interventions on communities, you know, live free or die. Well, you might die if you actually subscribe to that mantra. It was a really intense time, and I was sharing this with Jean, one of the members of the legislature that was tasked with looking at these statutes and updating them was so opposed, she actually refused to carry the bill through the process, and other people had to come in and do the work for the committee. These are really tricky issues politically when you have, sometimes the science is clear and sometimes it's really uncertain. And when you have that uncertainty, politicians don't like to take what's perceived to be controversial votes in the face of questionable or uncertain science. So I think the political sphere tends to run the other way in the face of uncertainty, which is at least in some ways why you need places like departments of public health that have clear laws, that have clear guidelines, so that in the face of an actual outbreak, they have some guidance on how to handle it. But I think it's interesting to think about how uncertainty in the political sphere politicians are really scared people. They're really afraid of constituents for the most part. So if you ever want to get your legislator to do your bidding, just make them a little afraid of you. That really goes a long way to have power in the building, in the legislature.
So we really want to engage the conversation. I have plenty of questions I can ask them, but you've got three really Well, before I open it to it, do either of you, any of the rest of you want to make another comment?
No, that was going to be my comment.
Okay, well, here we go. And there's a mic here, but it's not scary, so we like to invite people up, and this is a very willing and engaged panel, so.
I'm very interested in the piece that you just touched on, Carl, but that is sort of, I feel like, the bookend to this. On the one hand, we had a huge outbreak in a distant place and behaved in particular ways about anybody who wanted to go there or was coming back. But I'm really interested in how you think about the other virus, measles, and that we do understand and that we know what the consequences are, that seem to have still tremendous inequalities. And the movement about people who are opposed to vaccination that would keep others from getting a disease that has really devastating consequences. I mean, if you're as old as me, you remember seeing people become totally different from encephalitis. So how do we think in a time of worry about uncertainty and overreaction to a virus we don't understand? How do we think about this other movement that's happening in the United States and I don't know if in other highly resourced nations?
So there's Jean mentioned that I do human security work. And basically what that is a science that looks at how threats impact human beings at the individual level, right? So there's health security and how do they impact it? And so one of the things that it looks at is how do you keep threats from becoming disasters? How can you change systems so they don't have that impact? And so there's a lot of sort of science in there in terms of how people perceive risk. And what we know about how people perceive risk is if it's something that is above and beyond the risk that they have somehow subconsciously accepted as what is in their milieu, all of a sudden it's overemphasized. So Ebola is overemphasized because we don't know, it wasn't present on our radar, and all of a sudden, even if it's the most unlikely thing for people to encounter in the U.S., it still becomes a big concern. Whereas other threats like measles, like influenza, I mean, if you talk to people about the number of people that die of influenza, which I do every day as an infectious diseases doctor, both socially and in my office, you try to sort of engage people in that risk, but because it's a risk that already is sort of at some point been looked at and accepted, it becomes much, much harder to draw attention to that, even if it is a much bigger risk to people's safety. So that's really been my experience. And one way I think that I have worked on it is just engaging people at a personal level. Like, this is the impact. Like, this is what might happen to you. This is how many times higher chance it is. And it just takes more and more effort, I think, yeah.
And I wonder, I'm going to ask George to maybe speak to, so part of what's happening in response to the measles issue is people looking at tightening the rules in terms of students coming into school. Well, we're not going to mandate a vaccine, but here, so there's a series of laws across the country right now that are pending that will, disallow school entrance. Do you have thoughts about sort of the role of law in terms of shaping people's understanding of what's optimal public health response for them and others?
Yeah, I mean, I think the whole vaccination area, it's fascinating. I mean, the anti-vaccination movement, which did start just before 9/11, was the result of an article in The Lancet. It wasn't a result of idiots out there denying science. It was a result of parents actually reading the scientific literature, which turned out to be bogus, by the way. It was a study, not really a study, it was a series by this guy named Andrew Wakefield that thought that you could get autism by getting the measles vaccine. Just a nonsense thing. But it took, try to prove the negative. It took science more than a decade to discredit that, totally discredit it now. Wakefield's lost his license. But there's still a group of people out there who believe it. And it's very hard to change that belief. But again, I wouldn't blame them. This was a mistake that actually a major medical journal made, which started this whole thing. Now, I think we should work to get rid of it. I firmly support mandatory vaccination of kids. On the other hand, should there be a way to get out? You know, there has to be a way to get out. You're not going to strap kids down and vaccinate them against their parents' wishes. We know about herd immunity. We know about the science of it. We don't have to vaccinate every child in the United States to eradicate measles. We might have to, if you want to talk about other ways, you could keep measles out of Disneyland, but they would be pretty draconian. Disneyland even talked about, which is where the measles outbreak happened, but from people coming from other countries apparently, talked about checking everybody who came to Disneyland to see if they had the measles vaccine. I mean, they are just kind of nonsensical ways to do that. We're gonna I think we have to live with some risk. It's a tiny risk, but it does exist. With measles, we're doing good. There's a whole variety of diseases, right? That we can get to herd immunity and you'll be fine, right? Your kids, you're worried about your kids, get them vaccinated. Right? I know there are some kids who can't be vaccinated, and we've talked about that, and there were even suggestions that that their parents be able to sue the parents who don't vaccinate their kids. On what possible basis, right? Their kids are not at risk to their unvaccinated kids unless they actually get the measles and then go to their house and try to give it to them or go to them. But we got all kinds of weird stuff, and we were going to try to tell doctors they should lose their licenses if they didn't vaccinate all the kids in their pediatric practice. And we do have pediatricians, and this is an interesting argument, saying if you don't get vaccinated, I'm not going to take care of your kids. Right. Well, I think that's an overreaction. We can handle that in Massachusetts where there's like all kinds of pediatricians. You can go to another pediatrician. But if you're a community that only has one pediatrician, I don't think that's right. In any event, it's complicated. The interesting thing about the measles thing, that was like Ebola for a couple of weeks. It was on everywhere. Yeah. And everybody's trying to do different theories of how do we get these kids vaccinated. It's gone away. I'm sure there are still state legislatures that are looking at their exemptions. But hey, this is the United States. I'll tell you one thing. There's no way you're going to get rid of the religious exemptions. You might get rid of some of the philosophical exemptions. I don't know if it's worth it. That's the question.
So I really like this train of conversation. So what I'm thinking about is so we have science and scientific certainty or uncertainty, and you have law that is in theory informed by scientific thought and rational thought. But then you have this really powerful force called culture, and the people's beliefs and practices, whether it's about burial practices with Ebola or sexual practices with HIV. Like, culture is a massively powerful force that in many cases laws are not strong enough to overcome, and science, I'm going to go have sex tonight. Let's talk, forget science. I mean, those things go out the window when you're in a cultural context. Absolutely. And it's a really powerful thing. Think about the HIV context. We've known since the beginning of the epidemic almost that condoms are really effective. And I know many people, I won't say in this room, but probably in this room, that haven't been religious in using the condom every single time they've had sex. That's reality. We know that's the case. Why? Because we have 50,000 people in this country that got infected last year, most of whom got it through condomless sex, right? So right now we have a new intervention, pre-exposure prophylaxis, PrEP. It was clinically proven 4 years ago, FDA approved 2 years ago. It's one pill a day that's been FDA approved that is more than 90% effective at preventing HIV. And I bet most of you in this room don't even know that exists. How many of the room actually knew that PrEP exists? A few of you, yay, a few. But most of you don't, right? This is something that is a groundbreaking game changer for HIV, where people that are at risk for HIV could take a pill like birth control for preventing pregnancy, but a pill that prevents HIV, and nobody knows about it, and nobody's talking about it. So the idea that we have not just wonderful science, and we have insurance that covers this prevention, but it actually takes cultural acceptance and understanding and awareness, and that takes time. That takes time. So even when you have the best interventions with the best science behind it, sometimes it takes more than that to actually get something to be effectively implemented.
May I expand on, expand on this? It's interesting because the law is based on the science and the culture sort of, is driving the law and probably the science because we invest in what we think is important, right? But how many of you have a background in science in this room? So a few. So scientific inquiry. So we keep talking about this data. We keep talking about evidence, right? So what is evidence? Is that like the letter of the law? This is it. Like, this is the truth of, and in most cases it's not. What it is observations. It's a box of marbles with multiple colors. And what scientists are doing when they do studies or observations is they're putting their hand in there. So think of the box of marbles as a population. Everybody of different, shapes and colors. They're putting their hand in there and they're taking out a bunch of marbles blindly and they're trying to figure out, oh, do I have a good sense of the composition of what's in this box? That's what a study is, right? And so the more you sample, the better idea you have of what truth is. And the less you sample, you don't. And that's why we know less about emerging pathogens, right? And this is why the study in the Lancet, with the smaller series, even if that particular one, Wakefield actually admitted to having faked the data. But so that's what it is, and that's what we're basing all these things. So in the absence of enough sampling, what we do is we base it on expert opinion. We ask people who have had a lot of experience with similar things or a lot of experience in a particular field that's related and say, what do you think we should do? So it's interesting because a lot of things that are based on for example, 21 days. It's actually, a lot of it is based on expert opinion, and I won't mention names, but I was actually around people who were talking to a bunch of people who were very involved in Ebola very early on, when it was discovered, and they were part of this 21-day conversation, and they're like, yeah, that was so random, we just picked that out of a hat. So there you go, right? It was based on a bunch of observations that they had done, and then they based it on that, and that's where it came from. And 21 days, many, many years later, is what the country's fighting about a nurse, about how long she should be indoors. And we really have to keep in mind what data is. And that's why, we have to learn to sort of live with this uncertainty. And that's something that most people can't accept, even though we do. Every day we sort of take the chance of, oh, I might get hit by a bus. Right? We live with that uncertainty. Is there a 0% chance that you may get hit by a bus? There's never a 0% chance. Trust me. There's no such thing as 0% chance. So you live with that. Yeah, exactly. So you live with that uncertainty, and that's what I think it's a little easier when you're doing the research. You're aware of the data, so understand that uncertainty, and it's a lot harder when you're farther removed. Is my point.
So we'd like to hear from more of you. We've got a lot of young people here, and you're the future, and some of us are going to retire sometime soon, and we're going to hand it over to you.
Hi, how are you? My name is William, and I'm from Venezuela. And currently in Venezuela and in Latin America, there's a virus that's spreading. It's called chikungunya. Mm-hmm. And my question for you is, now, this virus is more than 65% of the population in Venezuela has had it, and it's recurring. There's no cure. There's treatment. You know what the treatment is? Painkillers. But that doesn't cure it.
Yeah.
Now, the problem in Venezuela is, well, apart from the socioeconomic problems, the government doesn't help. And I want to know what the perspective of the community is towards viruses that can become an epidemic but are not categorized as epidemics in the moment. You were talking about overreacting to an epidemic as it happened with the swine flu. But I want to know about underreacting and how maybe that happened with AIDS. Maybe AIDS could have been contained if it had, we read an article called The Terrifying Normalcy of AIDS, and it talked about the fear of, it even compared it to a nuclear weapon, like the mass hysteria and how like the media can alter things into making people fear certain things that can be prevented or controlled. Now, going back to my question is, when do you categorize? How many people have to die before you categorize a virus into an epidemic? Thank you.
Thank you.
It kind of depends on who's dying, doesn't it? It's interesting. I was talking to one of the survivors, and we were presenting the data on Ebola, and one of the things one of the speakers said was 1976 is when Ebola was discovered, and the guy raises his hand and says, wait a minute, this is an Ebola survivor. He's like, you guys have known about Ebola since 1976 and there's no cure, right? I mean, and what do you, so that's what it comes from. I think it depends on where it is. And by the way, chikungunya is now endemic to the United States. It's here too. Yeah.
Yeah, I mean, when did it become enough for the United States is when 2 white people were brought back to the United States for treatment. Really?
Your question of how many people have to die, if you ever read the book or seen the movie And the Band Played On, it's the history of the early AIDS epidemic, and there's a scene where Don Francis is working at the CDC, is pounding his fist on the table and saying, how many people have to die? And this was to force the blood banks to start screening the blood supply for HIV, and people were getting infected and were dying from AIDS from an untested blood supply. Why? Because it was costly to test the blood supply. And you have Don Francis at the CDC saying, so how many people have to die? Give me a number. Give me a number of deaths before we can actually change the policy. In the AIDS epidemic, it was called the gay plague or the gay cancer in the earliest days, and then Haitians started dying, and then hemophiliacs, and then it was straight people who weren't hemophiliacs or Haitian. What's going on? It actually took people to say, oh, so it's not the marginalized, it could be me, before people started to pay attention. What's interesting about HIV, today, the people that are still at the highest risk for getting infected are still people on the margins of society. HIV thrives on marginalization. It thrives in places of poverty, of racism and homophobia, transphobia. And I think that cultural element of how people see people as the other, and your comment really telling it, it's so powerful in these epidemics of whether we see people as humans or a statistic. And I think it's really important to remember that.
And, and I'll sort of bounce off of that. It's kind of interesting because I told you how Ebola is actually more of a diarrheal disease in this epidemic. People aren't bleeding from everywhere. They're just, and what is that? It's basically people lose all the fluid in their body. They're dehydrated, and eventually their organs shut down. They go into shock, and that's what people are dying of, right? So all it takes is good hydration, good supportive care, and we've shown that that has a very good impact on survival. So this one survivor came up to me, and he was telling, like I said, they start telling you stories about their own experiences, and he said, I hid because when I found out that I was getting sick, because I was afraid of going into ETUs, the Ebola treatment units, because I heard nobody comes out. So once I finally got sick enough, I went inside, and they put me next to this girl who was 10 years old. And he said, I've never seen another human being cry for water as much as that little girl did. Not enough nurses. People don't want to touch her, whatever the reason was, right? Not enough of physical resources. So in the morning, the little girl was dead. And if you really think about this, this was, 13,000 people, 10,000 people now who have died of Ebola, right? 10,000 people died of thirst in 2015, and it was acceptable. So it just depends on where it is.
Mm-hmm. I think the idea that's also really important when you think about your government, any government, the story that Carl just told, the story of how China handled the front end of SARS, the ongoing story about what goes on with avian flu, the challenge of having political structures that can hide information, choose not to engage it, and then having a public that doesn't understand how to engage it. So I think one of the concerns that I have about us engaging the issue of uncertainty and evidence as it's evolving is how can we get the public involved in saying, we want to know, we want to understand, we believe we want to be a part of a solution. And I think that piece of how it doesn't matter, it can be any of our governments, including a government in a rich country, that chooses to not engage an issue that feels like it's going to be politically problematic or potentially expensive. And so unless we're engaging the government and trying to push for that transparency, even if the information has a lot of uncertainty around it, we'll continue to have that challenge. But that was a great question.
Can I just pivot on that too? I think in the HIV context, what you just said about communities engaging with their government, you can't gloss over that as a lesson we learned in the AIDS epidemic. It wasn't until people dying of AIDS took to the streets and their friends and family took to the streets through ACT UP, and AIDS Action was a part of that history. People took to the streets staged die-ins in St. Patrick's Cathedral. I mean, really got really aggressive in their tactics with the FDA, with the CDC, with their government. I mean, Jesse Helms he was a very conservative member of Congress who was really opposed to any funding for AIDS research. They put a big fake condom over his house as a big stunt. Like, people got really creative and aggressive to force the media to start to pay attention to it. And sometimes it takes not institutions and not government, but actually citizens being really smart and really creative and sometimes really desperate to actually force that change to begin to happen.
Yeah,
So that was a great
absolutely. I'd
tool.
underline that.
Yeah,
I would
great question.
highly recommend, and The Band Plays On. It's a terrific book.
Great lesson.
And ACT UP deserves a lot of credit. I mean, they weren't the only group, but absolutely, nothing was happening until people felt threatened by groups like ACT UP, and they're absolutely right.
So let's hear from the good example of young people having good questions and older people having good questions too.
That's right, I'm with you.
Thank you.
You're welcome. I've got a question on the PPE.
Yes.
It has been cumbersome. It has been ineffective, uncomfortable for the clinicians, terrifying for the patients. Is anything being done to improve that?
Yeah, go ahead.
So- No, I was
Personal
gonna ask.
protective equipment. So that's what we wear to walk into the Ebola
space
treatment units.
suits.
The space suits. Right. And it actually did feel like that. It felt like you were doing missions in space because you couldn't breathe. You put it on, you sound like Darth Vader. And you walk out and you literally are like the clock is ticking. You know, your mission is to do this and this and this and this, and then you have to come out. So it's crazy that PPE hasn't changed in so many years, right? It's been the same that we have done it. And again, it's a matter of, we don't have as many infectious diseases as developing countries do. But actually, there's a huge amount of government funding and private funding that went into upgrading PPE, and there's actually 2 or 3 models, including one that's very promising at Johns Hopkins that is easily can be taken off, and you can see the face of the person, and it's very cheap. That's the other thing. It needs to be available very quickly. But, what I'll say is we have some options here. We had the alternate to what we were wearing, which is the masks, because you can't see anybody's face, is this astronaut hat, which is a PAPR. You have a breathing tube and you can walk in and so people can see you. It's more comfortable. You can stay inside for much longer. So we wanted to, at some point in January, I wanted to take some of those with me and I really sort of try to figure out how we can do this safely. Let's really improve this. And I couldn't find any. No company had any more because all U.S. hospitals had stockpiled them.
Yep.
Okay, good question. I saw another one over there.
Okay, so with regards to the people believing that vaccinations can give you autism, how do you think you balance bringing up a legitimate concern where you maybe don't have a ton of research on it, like something like that, with not having people, take it and just run with it, with and bring up a conversation, but not have it be totally stigmatized and dramatized and drawn out to a ridiculous extent?
I mean, it depends on the context, obviously, right? If you have, there are organizations, anti-vaccine organizations, and they have annual meetings, and I've actually spoken at one of them. That's a tough crowd to change their mind, because you actually literally are never going to change the mind of a mother whose child developed autism after they had a vaccine, right? There's no cause and effect there, but just that's beyond. You're not going to change it. That's their child. They thought they made a horrible mistake having it vaccinated. They're never going to do it again. The pediatrician's office, over a period of time, I've been told can be effective. Although there is some data from a small study that shows that it actually is counterproductive for the pediatrician to keep telling the mother that you've got to vaccinate your kid. It's a tough sell. It's tough. Once you have bad information out there, changing it is as hard as bringing good information out to begin with. It's difficult, but I don't think force is useful. I don't think holding the kid down and jabbing it. I mean, then you're going to develop a whole real cadre of resistance, kind of the Rand Paul libertarian resistance type, and you don't want that.
And even when you don't have bad science that goes out, Carl, you might want to comment about, so we spent a long time in the early HIV epidemic having people understand that, no, it couldn't be spread by mosquitoes. Or
Absolutely true.
couldn't be spread by using somebody's copper. And Carl, you might, I mean, there continues to be like a lot of fear that people, you spoke about it some earlier, but maybe you might speak a little bit about what are people doing to challenge those notions now?
Careful if you open that can of worms for me. So my first week at AIDS Action, I was talking to staff, and they had just worked with a client who was literally hiding in the corner of the office in one of their cubicles, sobbing and freaking out, just walking into our office because it says AIDS Action.
Right.
She was terrified just to walk into the space, that someone would see her, and she hid in the corner, was sobbing. Homeless, couch to couch to couch of friends and family, one kid, single mom. One of her medications, she had 2 different pills. One of them had to be refrigerated, so she couldn't put the refrigerated pill bottle into the refrigerator of the home she was visiting or couch hopping on because she didn't want them to know she had the virus. Really a powerful force. It's still very much with us right now, that kind of stigma. One of the things that I think we've learned in different social justice contexts, I think about homophobia, I think about racism, and in this case, about this stigma around HIV. I don't think you can really conquer stigma about HIV by teaching people that stigma is a bad thing. I can tell you all, stigma is a bad thing. Don't stigmatize people. And do an ad campaign, right? It doesn't actually really work. And the way you overcome stigma is to really empower those that are living with the stigma to feel empowered to overcome it.
Yeah.
So if you think about the gay rights movement, and there's a part of the gay community that self-identifies as queer, taking back that, disempowering that word. So if someone calls you queer on the streets, yeah, I'm queer. Okay, cool, whatever. It's like, it just empowers it. In the HIV context, it's something similar in a way I can't quite put my finger on yet, but if for me, living with HIV, I have this sense of stigma, this fear that people would find out that I have this virus, and I don't want people to know. Just because I tell you don't fear me for having HIV doesn't actually make me feel better. Actually, what's going to make me feel better is if I can learn to have confidence in myself that it's okay if people are afraid of me. It's okay if people reject me. Life goes on. You really have to empower the people that are experiencing the stigma, and that's a lot of work. And I think in our communities, part of the job at AIDS Action, for example, is to give people with HIV a space. I told you we have many people that are very closeted about having HIV. They don't tell many people in their lives. They can live their lives because they are healthy and people don't know they have HIV. But they need some social space to be with other people that have HIV, to have some common bond, to have some sense of community, to feel that they're part of something that they can overcome that stigma themselves. That empowerment of people is really powerful.
Let me I want to make sure that I understood it. It was your question that how do you allow people the space to question something without having them, right, okay. So I think we need to be better as scientists and doctors at communicating evidence and science. I mean, we're all nerds, sorry to say it. I know, we were not very good at public communication. That's probably why we went into science in the first place. Just kidding. But we do need a movement that allows doctors and scientists to be better trained to communicate with others who don't have our background. I think that's something we can work on. But the other thing I think that's missing is actually improving, so that if you can do that, the other is improving the understanding of the public of science. And with the funding decreases in science education, with the cultural elements that actually are anti-science, that education is not a good thing, that science is not a good thing, it's only going to get worse. So it requires those two things, and then you can actually have a conversation that is that allows both sides, to be on the same page. I think you start with that. I mean, and how else do you do it? I think you do it by what we do as physicians, allowing people to express their risk, giving them the time to do that. And I think we can all be better at that.
We've got time for 1 or 2 more questions, so. And you can be ready right next, okay?
I just have a question about advocacy. For me, one of the hallmarks of the 30 years of HIV has been advocacy, community advocacy, and it has led to sweeping change. So I'd like to put this to, I don't know if we have time for this, but to all three panellists. What can we learn a year into this current outbreak, not just about preparedness and response from a national and international level, but about advocacy?
Boy, what a great question that is. I'm almost going to say nothing, but I mean, there's no Ebola Action Committee, right? As far as I know, there's no organization of patients who have Ebola or who have recovered from Ebola. There should be. I mean, that would be actually, I think, a really, well, you just were talking to recovered people. Is there any opportunity to organize them?
Yeah, they actually, that's one of the, we keep talking about survivors as, oh, maybe we can take their plasma because they may be immune and they might, you know. We don't know if it works or not, right? Or then we're saying, oh, we can send them into ETUs and they can help us, you know, take care of other patients because potentially they're immune. And actually, that's one of the reasons I did this training, because we don't have enough evidence. We haven't sampled the marbles enough to know if they're actually immune or not. So we should really be putting them in the same PPE as everybody else. But what they want to do, because like I said, they don't talk about how they were, what they were treated with, they talk about how they were treated. They say, I wish someone had talked to me like a human being. I wish someone had done this. And then at the end of the meeting, one of them said, well, we could do this. We could be the advocates for the patients that are coming in, for the Ebola patients that are coming in, you know? And so that they actually, the Ebola survivor network is getting a little bit more formalized. I think hearing their stories, having providers, you know, I'm a very paltry 17th or 18th, you know, like exchange of information to you about what their experience is. Hearing their experiences can be so powerful. My God, you know, I just, it was interesting for me to be in a very horrible, hard experience to be a provider within the ETUs, but to hear their experiences of being on the other side without any PPE on, right? They didn't have any PPE on. I had an armor on. It was powerful, and we need to hear the stories, and I think that's probably one of the things that we can do is get their voices heard and hear about their experiences and realize so much of this was injustice. It wasn't actually hard to control this, it just wasn't, it wasn't political. Yeah.
When I think about advocacy, I got really good advice from one of my state rep colleagues my first term, and he said, when you're trying to figure out whether you want to file a bill or work on a policy, you first want to ask yourself, what's the problem you're trying to fix, and does this fix that problem? And when I think about the question of advocacy, in this case, I guess I'm struggling with what the lesson is that we should, what is the problem that we need to be fixing that we saw manifest in this most recent outbreak? And I think one of the things that I would point to, and I'd love your reaction to this, but it's the sense that in this case we had people going around the globe to help very marginalized people in very isolated places. And in some ways it's the concept of compassion without borders. And we are such a segregated world with these borders in the sense that when it's on the other side of the globe, we don't worry about it until we think it might come and hurt us. And I think the power of the stories of the people that experienced the Ebola outbreak and continue to do so teaches us that we are very interconnected. And that fear was experienced here because people realized maybe it won't stay isolated. Maybe it won't just be those people in Africa that are dying of Ebola. Maybe it'll come home to us. And so the intervention around the globe needs to be, I don't know. I feel like there's more work needs to be done to actually, the Doctors Without Borders and the sense that we have a responsibility to people around the globe when these things break out, not just to contain, but to actually build sustainable infrastructure for not just that outbreak, but beyond, I think might be one of the lessons I'm grasping at for this recent outbreak.
Yeah, I think it's what that guy said, you know, it's been 1976 and how come there's no treatment for Ebola, right?
Yeah.
It's that. What was missing from this is that we didn't have ever enough resources, either scientific resources, response resources, in diseases, neglected diseases of the poor. So if anything, that's, I think, the advocacy goal is to try to make sure that we have enough of those things moving forward. And it's always a tricky thing, right? How do you draw the importance of this by saying, hey, you know, it affects all of us, it could affect you, and then turn around and say, oh, don't worry, it's across the border, it doesn't affect you, right? It's kind of this balance, because we do want to draw those two.
A little bit of fear, a little bit of answer.
I want to welcome up our last question, and then she's coming up. I want to reflect that I think where Carl took us with the advocacy. Pat, you want to do your question? Where you took us with this is that the advocacy here is not inherently a consumer-based one, although there's clearly a role for it, as Nahid said. It is really about all of us in this room and elsewhere, and understanding that that's part of the fabric of our community, even if it's far away, so it matters.
Okay. Hi, I'm Bella. Okay, so in my opinion, I believe that society, or people are misinformed because of media, because when media catches wind of something, they, like Adam said, they run with it, and then like you said, they create this epidemic of fear. And I was wondering what you guys think about media's role on viruses and how you think it's affected, like Ebola, HIV, and all the other viruses.
And that's a great place to end, because we've got to go out and communicate, so. Could start with the former legislator and move on down.
So I'm thinking about my own role now in AIDS Action, and when I deal with the media around the work that we do, like we have the AIDS Walk in June. It's our 30th AIDS Walk, and we talk to the press, and they're like, oh, but AIDS, that's like an old story, you know. In some ways, it's like, if only we could scare them into doing a story, right? If we had some fear to give people, maybe they'd be wanting to write a story about HIV, because HIV is not in the headlines anymore, because people aren't afraid. And I don't want people to be afraid, but I think there's still an epidemic that people don't even understand or appreciate right now. And so part of the challenge is, if any of you do media relations or want to get into PR, like the press has its own agenda, and we, as people that have values that we want to convey and articulate and a mission to live out, have maybe a responsibility to manipulate the media for our own purposes. Sometimes that might include striking a little fear and reminding people that, yes, people are still dying, or that things are not perfect. But I don't know. It's an interesting question. How do you deal with the media? And I'll stop there. Yeah, I can keep going on this.
I mean, the media is trying to entertain you, trying to get your attention, and it's only interested in things that are sensational. Or there's two sides, so they always ask, well, which side are you on? I'm not on any side. Well, I don't want to talk to you. Can you tell me who's on a different side? But I also think that, and that's true, and it's very sad and everything, but there's a whole new media, and you guys run it, and Twitter and social media and BuzzFeed and all that, but I don't even know what the hell that's about. But you do, and you can take that over. I mean, you actually can have a major influence on the new media, and don't look to us old guys to do that. You do that.
Yeah, I was just going to say that, actually, you know, part of the reason why there's so much media cycle, you know, frenzy is because old media might be dying out, right? I mean, the news travels faster, you know, as fast as a tweet. Like, the first tweet goes out, all of a sudden it's like RT'd everywhere. I don't know if that's the right way to say it.
I don't even know what you're talking about. I trust you.
So, but literally, tweets make news these days. I watch CNN, and they're like, so-and-so tweeted, blah, 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 you know, and it really is like Facebook with the Arab Spring, you know, like I really think that social media, and hence us, it's actually democratized media in some ways. And so we really have a lot more influence than we think we do. Yeah.
Absolutely.
Yeah.
Well, there you go. You've got your mission and your message going out. Jen, I don't know whether you want to, I want to thank everybody, and